Today we are talking about PCOS and Hashimoto's disease and the connection between the two of them. This event is hosted by Paloma Health. We are an online medical practice focused exclusively on testing and treating hypothyroidism and Hashimoto's disease. And we're joined today by the team at Allara Health, who are focused exclusively on PCOS, or polycystic ovarian syndrome. We are also joined by Mary Showman as our co-host. Mary is a thyroid health coach, a thyroid health patient advocate. She's a New York Times bestselling author. She's written 15 books on thyroid health and function, and she's an advisor to Paloma Health. So between Mary and our two speakers, there's really a wealth of knowledge in the room tonight. This event is about 60 minutes long, and there will be time at the end for live Q&A. So as you're watching and listening to the speakers, go ahead and drop your questions into the chat feature at the bottom of your screen, and we're going to get to as many as we can at the end of the event. Without further ado, Mary, I'll pass it over to you to tell us a bit more about who you are and what you do. You can introduce our speakers, and then we will get into our questions.
Thanks, Katie. I'm Mary Showman, as Katie said, and I have been a thyroid advocate for 25 years now, I think, and counting. And I'm really excited about today's topic, which is polycystic ovary syndrome, PCOS, and thyroid issues, because there's so much crossover and there are so many questions, especially in women of reproductive health age, about whether they might have a thyroid condition if they have PCOS, or do they have PCOS when they have a thyroid condition. And some of these conditions are misdiagnosed as one or the other. There's a lot of crossover. And it's really an important issue because PCOS affects so many aspects of our health, much like thyroid does. So we're really excited to have two guests with us today, guest speakers, Dr. Stacy Henigsman, who is an OBGYN at Allara Health, and Felice Ramallo, who is the lead dietitian at Allara Health. And they are going to be sharing with us some of their thoughts about the PCOS and thyroid and Hashimoto's relationship, and really helping us understand both the physical and lifestyle issues that can go into getting a handle on this condition and living our very best life. So I'm going to start by introducing Dr. Stacy. Dr. Stacy Henigsman is part of the care team at Allara Health, and she strives for a truly collaborative doctor-patient relationship and really makes it her goal to be a provider of the highest level of gynecology. She believes it's important to treat every aspect of the woman's life, physical, mental, and social. So it's right on board with our approach for Paloma with hypothyroidism as well. Patient education is a vital part of her practice, and she feels education always leads to better health outcomes. So we are excited to have Dr. Stacy here to help educate us a bit more about PCOS. So I'm going to turn it over to Dr. Stacy to give us a little bit more background on her thoughts about the issue today. Thank you.
Thanks, Mary. Good evening or afternoon, depending on where you've joined us from. And I'm so very happy to be here today and so glad that you could join us. So as Mary said, my name is Dr. Stacy Henigsman, and I've been an OBGYN for a little over 15 years. And I currently work as a gynecologist for Allara, which is the first ever telehealth platform that treats women with polycystic ovarian syndrome, or PCOS for short. And today I'm going to be talking about PCOS and the relationship that PCOS shares with Hashimoto's thyroiditis. And I'm very, very interested in this relationship because it's so often overlooked in the medical community. And as we'll find out, the two conditions overlap so much, and it's really important to look at both when evaluating a woman's hormonal health. So thank you.
Okay, unmuting here. And I am going to now introduce Felice Ramallo to talk to us a little bit about her background. Felice is a registered dietitian nutritionist who specializes in women's telehealth care for polycystic ovarian syndrome. She did her BS in nutrition at Syracuse University and an MS of clinical nutrition and a dietetic internship at the University of Buffalo. Felice practices nutrition from the intersection of your dietary patterns, lifestyle, mental well-being, and relationship with body and movement. So it sounds like a very integrative approach that Felice is bringing to the table. She integrates the principles of intuitive eating and health at every size, at a particular philosophy, and with the goal of helping people find both joy and optimal health through food. So Felice, I'd like to introduce you to the group and ask you to say a few things about your overall approach and interest in the topic.
Well, thank you, Mary, for that introduction. I feel like you've said it all. But as Mary said, I'm the lead dietitian at Allara Health. So I help design all of the nutrition protocols over there. I live in upstate New York, and I did my education all in upstate New York at Syracuse University and then the University of Buffalo. While I was at UB, right at the beginning there, I was actually diagnosed with PCOS myself. My symptoms were a missing period and drastic weight gain. All the women in my family have thyroid disease. My mother has Hashimoto's, my aunts and my grandma have thyroid disease. So that was honestly where my mind was going first. I thought, just like everybody else in my family, that is going to be my fate too. Come to find out, they are very related conditions. They're often seen together, but I just have PCOS. And I was able to, get the testing and the diagnosis and come up with a wonderful plan with my provider. And I was also able to translate everything that I was learning and all that I was researching for myself into my master's thesis while I was at Buffalo, where I wrote about nutrition counseling for polycystic ovarian syndrome, because there's so much to unpack, so much to understand with the psychosocial impacts of the condition, just like with Hashimoto's. And really ever since, my career has been dedicated to treating the condition, and from a health at every size approach, really understanding that behaviors drive all of those health outcomes, and really treating the person first, their behaviors, making sure that they have the mental health care that they need, that they're getting the movement that they need, and then for me to provide that piece as well for nutrition, to put together, a holistic, integrated package that, really drives results and puts you in a place where you're going to be happy and healthy for a really long time.
Terrific. Thank you, Felice. So as you can see, everyone, we've got two really superstars in this arena who have dedicated a tremendous amount of attention to the issues of PCOS, thyroid, and how we can get to a place where we can feel and live well with these conditions and know the difference between the two, because that's an important factor as well. So typically, Paloma, we usually will put together a few key questions that we really want to see answered. But remember that as we get to the end of the session, we will have time for a Q&A from your viewers. And all you need to do is drop your question in the chat at any point along the way, and we will do our very best to make sure that our experts have a chance to address them before we finish up today's session. So if there's something you have a question about that you're hearing, please make sure you drop it in the chat box. So we'll go ahead and start with our first question, which is for Dr. Stacy. For those who may not be as familiar, and also just as a refresher for those of us who may have some knowledge, can you tell us generally what PCOS is and what's the connection between PCOS and Hashimoto's and hypothyroidism, and sort of how they go back and forth? So give us a bit of an overview about that, if you would.
So I actually prepared a little slideshow because it's a really complex topic. And so I think it's easier for everybody if we can just go through this. So bear with me. Hopefully everybody can see this. So what is PCOS? So basically PCOS is a hormonal disorder that's very common among women of reproductive age. And in fact, about 15 to 15% of the female population actually has PCOS. The symptoms of PCOS, they have infrequent menstrual cycles, excess androgens, male hormones like testosterone, and their ovaries develop numerous small follicles. And it's really a very complex disorder with multiple factors that contribute to its pathophysiology. And it's, I think, really the complexity and how the diagnosis is made is one of the reasons that it can be very confusing for women who are diagnosed with this condition. So I actually made this slide, and it's a very busy slide, but this helps visualize the complexity of PCOS and the interconnections at the brain level here, the ovarian level, and the adrenal gland level, and what I like to call the peripheral level with insulin resistance and hyperinsulinemia. So how do we really diagnose PCOS? Well, we diagnose it using the Rotterdam criteria. And that is basically 3 things that we use to help diagnosis. So hyperandrogenism, which is kind of what I talked about before, which is slightly elevated male hormones like testosterone, and the clinical manifestations of increased facial hair growth, acne, or hair loss. The second criteria is oligomenorrhea. And what that is when you don't have your period as often as you should. And technically, it's very specifically defined as less than 8 cycles per year. And finally, polycystic ovaries. And that is just multiple ovarian follicles seen on ultrasound. And you must have 2 of the 3 criteria. You only need 2. And they can be any different 2. So you can have hypoandrogenism, with oligomenorrhea. You can have polycystic ovaries with oligomenorrhea. You just need 2 of these criteria. So then the question becomes, what do we know about PCOS and Hashimoto's? Well, we know that PCOS is a complex multifactorial disorder with a very strong heritable component. And we see a familial component accounts for about 72% of the risk of developing PCOS. We also know there's a very strong genetic predisposition to Hashimoto's thyroiditis. And it's said that over 70% of Hashimoto's can be attributed to genetic factors. And interestingly enough, patients with PCOS are 3 times more likely to have Hashimoto's. So why are patients with PCOS more likely to have Hashimoto's? The fact really is we don't know. But there are some theories, and they are doing genetic studies on this very thing. So the first theory is that we know that Hashimoto's is an autoimmune condition. There was a very, very interesting study done in 2013, which suggested that PCOS may also have an autoimmune etiology. They found in this study that there was elevated levels of systemic autoimmune markers, such as double-stranded DNA and anti-nuclear antibodies, in some women with PCOS. And we know that having one autoimmune disease predisposes a person to more autoimmune diseases. So perhaps there is an autoimmune connection between Hashimoto's and PCOS. There's another theory that said perhaps this could be from genetic mutations that are associated with both diseases, which make them occur together. They've looked at this study, but really to date, there's only a few genetic mutations that are common to both disorders. So what we really think, our current knowledge, is that PCOS and Hashimoto's lead us to believe that there are a specific combination of risk factors for both diseases, which predisposes them to occur together. And this interesting slide that I put together shows PCOS over here and Hashimoto's over here, and all the interconnections between them. So for example, you can see GnRH, which is a hormone released by the brain, can actually go over and cause an increased level of TSH and a decreased level of T4, which is common in Hashimoto's. And those thyroid hormones can go over and cause insulin resistance in a patient with PCOS, which in turn can cause ovarian dysregulation. So that's just one example of how PCOS and Hashimoto's are combined. And so really, we think that the most likely theory is there's a specific combination of risk factors for both diseases, which predisposes them to occur together. So hopefully that kind of helped answer the question of how Hashimoto's and PCOS are connected.
Wonderful. That's a great overview. And, you know, as we can see, it's a complicated topic, but I think taking it down to its most basic level is that both conditions seem to have some genetic component and run in families. There's crossovers that may be affecting each other. And if you have one, you should probably be thinking about whether or not the other one is there and being evaluated to look for that. So let's turn over to Felice. Felice, can you tell us about some of the most common signs and symptoms? Dr. Stacy gave us an overview of some of the key things to look for, the higher androgens, the ovarian cyst, but I'm guessing that there are probably a lot of other symptoms that may be associated with a PCOS diagnosis.
Yeah, absolutely. So first I thought I'd talk through some of the outward symptoms, the symptoms that you're probably going to notice first if you have PCOS. So that could be acne, weight gain, terminal hair growth. So on the arms, especially upper arms, back, legs, it gets darker and thicker, more like male pattern hair growth. Then hair loss on the head. So you might see your part widening or more thinning around the temples or on the crown. Missing periods, certainly, anxiety, depression, skin tags, darkening of the skin around the groin or the armpits, the neck. The skin tags and the skin darkening actually have to do with insulin resistance. And so switching over to more of those metabolic and hormonal internal symptoms that we can find with PCOS is an elevated insulin resistance. And what that means is that our cells are not properly responding when our body releases insulin as a way to tell all those cells, accept some of that blood sugar that's circulating throughout the body. So as a result, blood sugar can rise, and as insulin resistance gets worse, that can progress to type 2 diabetes. That is also very closely related to the elevated androgens like testosterone that Dr. Henigsman mentioned, that oftentimes drive the missing periods and the increased cysts on the ovaries. And additionally, all of the kind of chronic diseases that we classify as metabolic syndrome, like hypertension, high blood pressure, dyslipidemia, or high cholesterol, those are also seen much more regularly with PCOS. So the condition is associated with not only an increased risk of type 2 diabetes, but unfortunately stroke and heart attacks as well.
Okay, so we need to pay attention to these things, and you know, it's kind of like the worst combination is we're getting hair on our face and losing hair on our head. I mean, who needs this? This is not what we want. So we definitely want to pay attention. Back to Dr. Stacy. We're talking primarily to an audience tonight of people with Hashimoto's or hypothyroidism. And when we're talking about some of these symptoms that they may have experienced, even in the past, you know, we may have women that are in their 40s and 50s. They're not looking to get pregnant anymore. They may not even be having regular menstrual periods. They may be in perimenopause, but they're thinking, well, you know, I had a couple of times I had cysts, and, you know, I always gained weight, and my blood sugar's always been high. Or we have young patients that are going through this. What should a patient do if they suspect that they might be a candidate for a PCOS diagnosis? What's their next step? So Dr. Stacy, walk us through that if you would.
So if a patient comes in to me and has the symptoms of, you know, irregular periods, facial hair growth, difficulty losing weight, then I'm immediately going to think of PCOS, and I'm immediately going to think of thyroid. The two conditions overlap so much that you really have to check for both conditions. At Allara, all of my patients are checked for a full thyroid panel because, like I said, it's 3 times more likely in women with PCOS. So those things have to be checked. Now, if you have a thyroid condition and you're wondering, well, do I have PCOS? Is this just thyroid? You can really look at the hyperandrogen component of PCOS because that really does seem to differentiate between PCOS and hypothyroidism. So typically the Hashimoto's patient's not going to come in with facial hair growth. They're not going to come in with any kind of like underarm what we call acanthosis nigricans. They can, but it's much more rare. So if a patient came into me that had Hashimoto's with these other symptoms of excess androgens, then I would definitely want to check them for Hashimoto's. But really, these things have to be checked all the time in both patients. So if a doctor is just checking one, they really need to check both of them because they are so interconnected.
And the testing then for PCOS is primarily a blood panel looking at the androgens and blood sugar and insulin resistance evaluation and metabolic factors?
Yes, correct. So we do a full testosterone panel. We check their adrenal hormones, DHEAS, and also 17-alpha hydroxyprogesterone. We do a full thyroid panel with TSH, free T4, and also anti-thyroid antibodies. So we check that. We check glucose. We check insulin. We check what's called C-reactive protein because a lot of patients have increased inflammatory markers in their blood. So we check that along with estrogen, progesterone, prolactin. So it's a full comprehensive panel and workup that the patients that come to Allara get, along with thyroid. We check both in all patients, and they really need to be checked both every time with these type of symptoms.
Mm-hmm. I'm going to actually jump in early with a question here because I think it's something that we might want to clarify up front. I was talking the other day with a coaching client of mine, and she said that she was perimenopausal now, but she said, you know, in the past, I had a point when I started to grow a lot of facial hair. My skin was breaking out. I always had a problem with fertility, and I had to go get serious infertility treatment to be able to conceive my children. And I gained weight and my blood sugar went up and all this. And I said, well, did you ever get a diagnosis of PCOS? And she said, well, they checked me one time and I didn't have any cysts at the time. So they said I couldn't have PCOS. And I said, did you ever have cysts at any point? She said, yeah, I had a few that came and went and resolved, but they said I never had PCOS because I did not have a cyst when they did the ultrasound at that time. And I said, you know, I think that sounds to me like you might have had a PCOS and you probably ought to explore a little more your male hormones and some of the other issues. But is that a common problem that somebody even their doctors might think you have to have cysts active at the time of evaluation in order to be diagnosed with PCOS?
So that's actually a very good question because when this condition was first diagnosed, they put that you had to have multiple cysts on your ovaries. You had to have it. Then they took that out of the criteria for many years, and now they put it back in the criteria. But what's nice about the Rotterdam criteria is you don't have to have multiple cysts on your ovaries. That's only one component. So you only have to have 2 of the 3. So you can have no cysts on your ovaries, but still have oligomenorrhea, still have hyperandrogenism, and there's no cysts. So having cysts on the ovaries definitely does not diagnose PCOS. It is most typical to have all 3 symptoms, all 3 of them together. But I mean, there's 4 different phenotypes depending on, meaning how the gene is expressing itself, depending on exactly what you have. So you can have all 3, you can have 2 of the 3 in any combination. So to answer your question, absolutely not. You do not have to have cysts on your ovaries for the diagnosis of PCOS.
Okay, thank you. We're going to jump over to Felice to talk a little bit about some of the integrative and nutritional and lifestyle issues that come up. We know what the symptomology sounds like. We know what it feels like and looks like for people that are experiencing PCOS. And we'll go back to Dr. Stacy in a moment to get some specifics on some of the medical approaches on how to treat it. But I'd like to start with Felice on the role of diet and nutrition and even lifestyle issues in dealing with PCOS symptoms and potentially resolving the condition. I know I have a very good friend who had PCOS and was told she was going to have fertility issues, and she did a complete radical overhaul of her diet, did some medical intervention, did some metformin, but also changed up her diet dramatically. And she was able to conceive, lose 50 pounds and conceive and get her blood sugar under control. So I know that there are a lot of interventions that can really make a difference. So Felice, tell us a little bit more about that element of PCOS symptoms and resolution.
Yeah, so I just want to start off by saying there's no such thing as a cure, unfortunately, to PCOS. The last part of the word is syndrome, or of the name is syndrome. So that means that there are going to be components of this condition that can change throughout your lifetime and that may come in and out of affecting you at one time versus another. So we can certainly treat symptoms and prevent larger issues from coming up, improving labs, all of that. But there's no such thing as a cure, as it completely going away. Just potentially taking really good care of it and maybe not having such a severe case. To understand, the treatment for polycystic ovarian syndrome and or Hashimoto's, it's important to understand that inflammation is the driver here. It drives the severity of the condition, how the condition is going to be affecting you, and just thinking about that diagram that Dr. Henigsman had shown with all of the different arrows between Hashimoto's and PCOS and all of those different, boxes, names that I'm sure nobody understood. Those are the signaling pathways that tell genes to turn on and off. And the wonderful thing about lifestyle treatments is they can help our genes decide what parts to turn on and off. So we can turn on and off pieces of that puzzle, parts of where those arrows are pointing to, through diet and lifestyle. When I talk about that type of intervention, I typically give my tricycle analogy, which is thinking about, the front wheel of a tricycle. The biggest wheel, the one that's driving us forward, is mental health. It's everything that's happening up here. It's dealing with stress. It's getting enough sleep. It's, that sort of preventative maintenance of self-care. That is what's going to drive the rest of your health. It doesn't matter how much you exercise and how much you eat or what you eat if it's not first taking care of your mental health. And then the two back wheels are, of course, physical activity or movement and nutrition. And when it comes to living an active lifestyle, there's kind of two main components there for both PCOS and Hashimoto's. One is just find ways to get active throughout your day. Whether that's walking around a little bit more, taking stretch breaks. Also, aim for a minimum of about 150 minutes. So if you think about 3 days per week of working out, that could be 50 minutes, 3 days per week, of any type of organized activity. And I use the word organized so that we understand it's actively doing some sort of exercise, some type of movement, but it can be any sort of variety and mix of things that you enjoy. So it's important to get a little bit of cardiovascular movement. So anything that really gets your blood pumping, works your lungs, you can feel your heart pumping. And then the other type is any sort of strength activity. So that could be body weight or resistance or weight lifting. So getting a mix of those two things for 150 minutes per week. And then when it comes to nutrition, keep it simple. Don't follow the big trends. Generally, just eat a variety of, those foods that your mom or your grandma would want you to eat or tell you to eat, like those fruits, vegetables, whole grains, beans, mostly plant foods with some nutrient-dense oils. So thinking about really healthy plant oils like extra virgin olive oil. Some dairy is also shown actually to improve both conditions, particularly full fat dairy. And then also some animal protein, if that's what you'd like as well. If you want to include some animal products, those are, perfectly fine for either condition. So just kind of to sum it all up, focus on a few things at a time, take care of your mental health first, and just pick a couple of areas that you can begin taking small steps and improving on, whether that's for your mental health first or your lifestyle, adding a 10-minute walk or something like that to your day. And of course, just getting a good variety of home cooked, minimally processed foods that are mostly plants.
Terrific. Well, that gives us a really, really good overview of just a sort of an integrated approach to dealing with this as part of our life, part of our overall health. So let's go over to Dr. Stacy for the approach to medical treatments for PCOS, because I know that there are prescription medications and other types of medical interventions that are sometimes used to help manage PCOS and its symptoms. So can you run through those for us?
Yes, I'm going to share my screen once again with this horrible slide. We're going to go on to something a little bit better. Okay, so the medical treatments for PCOS, basically like Felice said, you're never really going to get rid of this syndrome, but you're going to keep things under control. So there's menstrual cycle control, there's medication to decrease the hyperandrogenism that comes with PCOS. Fertility and pregnancy is huge in women with PCOS. They're very concerned about this. There's definitely a cardiometabolic risk. And like Felice said, a huge mental health issue. And we did not talk about this before we gave this presentation. So Felice and I are on the same page here. So with menstrual cycle control, I kind of like to look at this as not just, oh, you need to control your period and this is why. This is actually, there's a very good medical reason that we need to have periods, and it can be very dangerous for women with PCOS that don't. So as I stated before, oligomenorrhea is very common in PCOS, and the problem with that is it leads to unopposed estrogen exposure, and this increases the risk for endometrial cancer. So that's really the biggest concern as a physician in women who aren't having periods. So there's a couple of things you can do to protect your uterus, and that's what I use birth control pills and other hormonal methods is basically to protect the uterus. So you can use combined hormonal contraceptives, so that's an estrogen and a progesterone together. You can use cyclical progestins, so just progesterone only, typically in about 10 days out of the month, you'll use that medication. Or you can have a progesterone containing IUD placed. And again, this is really to help women protect their uterus because it's very, very important. The next thing which really bothers a lot of women is the hyperandrogenism. So the clinical signs of that we talked about, it's facial hair growth, acne, and hair loss. So again, combined hormonal contraceptives are really good at decreasing the androgen levels in women, but you have to make sure it's the correct birth control pill. So you need a less androgenetic progestin, such as drospirenone, or there's other different progesterones that you can use. So it's really important to go to a physician that understands the androgenicity of different birth control pills to pick the right one for you. There's also spironolactone, which is actually an androgen receptor blocker. So it's going to block the androgen receptors in facial hair, in your scalp. And so that's going to decrease testosterone and help with some of that hyperandrogenism that women with PCOS experience. Then there's also minoxidil. That's used for women who have thinning hair if the other medications we're using is not working. So that's basically the treatments for hyperandrogenism. Fertility and pregnancy is really big. Basically due to decreased ovulatory frequency, patients with oligomenorrhea experience subfertility or infertility. So there's medications we can use. There's oral ovulation induction medications like letrozole and Clomid. And there's also metformin, which decreases insulin resistance, and it may increase ovulatory frequency as well. Then the biggest issue, I would say, and the one that we really like to control is the cardiometabolic risk. So Felice already described that insulin resistance is detectable in a majority of individuals with PCOS, and it contributes to both reproductive and metabolic dysfunction. So metformin is really, really good for this. Lowers insulin resistance. It helps with weight loss. It actually helps with lipid profiles. It lowers LH. It lowers testosterone. So it's really a nice medication. There's also a medication called Saxenda, which is a diabetic medication. It's an injectable, but the FDA has just actually approved an oral version of this, which I'm really excited about. There was a study done in 2014 that said the combination of metformin with Saxenda in patients with PCOS caused definitely more weight loss, but really good lipid profile. And so that's what's really important when you're looking at the cardiometabolic risk of women with PCOS. And finally, as Felice touched on, the mental health aspect. So women with PCOS really have an increased risk of moderate to severe anxiety, depression syndrome, disordered eating, and these symptoms really need to be addressed routinely. And really referrals to mental health professionals as indicated needs to be done. So a woman with PCOS, you have to address this mental component really before anything else in order to get the most benefit out of your treatment.
Okay, thank you. That's an excellent overview. So if you are going to see your doctor for PCOS treatment, let's hope that they are as thorough as Dr. Stacy at laying out all of the different options and all of the different alternatives. I am going to jump to a question that we have from one of our viewers. And I think maybe we'll see if Dr. Stacy, you may be able to jump in on this, and Felice, if you have any thoughts about it as well, we welcome them. Our viewer said that she had irregular periods for years. When she was young, a doctor told her she might have PCOS and put her on a birth control pill. She took that for a few years, didn't like how she felt on it, stopped taking the birth control pills. The period was still irregular until about a year ago at age 32. Now it's coming like clockwork each month and it's completely regular. So she's wondering, could her period have just corrected itself like that? Could she have had PCOS that resolved itself? And that sort of also leads into another question that we had from a viewer, which is, what age is PCOS an issue? Can you have it at 14? Does it happen in your 20s? Does it matter if you're 45? So if you can kind of touch upon both of those issues, our particular viewer's question, and then the issue of the age issue for PCOS.
So I'm going to start with the age first, and it's really interesting because it kind of goes back to what causes PCOS. So the newest research says that perhaps this is something that happened in utero with increased testosterone and depositing increased fat among visceral organs. So that's really, really interesting. And there also may be a genetic component. So we're seeing this younger and younger. So when I talk to my patients, they will say, I had a regular period since I started my period. And that's typical. And so we see this very, very young, and they're actually doing right now more studies in adolescents with PCOS to see how best to treat them. And so the answer is it can really start at any age, but probably it started very young and you were just diagnosed in your 20s or your 30s or your 40s. But if you look back, you'll see, well, maybe I was a little bit overweight as a child and that's what caused more weight gain as an adult, or maybe my periods were always irregular. My mom had some problems with infertility. So it's a genetic component and perhaps maybe even an interutero component that they're doing studies on. So really the answer is any age, you can have it. You can have it at 12, you can have it at 45. So age really doesn't matter with this. I think probably we see women in their 20s because they've had irregular cycles for a long time. They want to get pregnant. So we just associate PCOS with 20s, late 20s, but really any age can have it. And then the second question is likely it didn't just resolve. Maybe something got better. So maybe she lost some weight, or she started eating healthier, or she started exercising more, or something changed to make her periods more regular. Also, as you age, sometimes your periods with PCOS can get irregular. You start producing a little bit less estrogen. I mean, 32 is a little early for perimenopause, but I have seen it happen. So maybe something hormonally happened at that time. And so it's hard to say. But again, the oligomenorrhea part of it is only one component. So you can still have two other components and be diagnosed with PCOS. So it's not real, it's great that the period is regulated, but that doesn't mean you don't have it. I would still get checked just because of the long history of the irregular cycles.
Great, thank you. That's a really good information. Felice, did you have any more thoughts about the age issue? Because I'm guessing that you probably are talking with women of a variety of ages as well. And one extra question that I have actually for both of you is, once you're perimenopausal or even menopausal, can you still have PCOS?
Yeah, so I mean, I think Dr. Henigsman did a beautiful job of covering everything that has to do with age. And to answer, I guess, the later part of your questions there, it can certainly continue, and especially hyperandrogenism can continue into after your menopausal years, which I'll let Dr. Henigsman go in more depth about if she'd like. But just kind of talking about some of the patient experience and how they experience PCOS throughout the ages. I've had patients that have come and said from a very young age, I was showing, excess hair growth even before having my first period, menarche. Or maybe, it was always very difficult for me to lose weight or stay within that healthy BMI range, which I don't love to begin with, but it's a good kind of benchmark that everybody knows. And then I'll just speak from personal experience. For me, it definitely got worse as I was in my 20s and all of that. In my late teens, I didn't have any symptoms. It was very easy for me to maintain a healthy weight. And kind of the impetus for me, that the only thing that I can kind of pinpoint when I started showing symptoms is my husband's mother had passed away. And then shortly after that, it seemed like everything health-wise kind of crumble apart for me. So I certainly see anecdotally and personally that there sometimes can be sort of like a stressful event or a moment where a lot of things change and then you start to notice or develop these symptoms. And for other people, it really truly is just randomly throughout their life that they begin experiencing it.
Okay, thank you. Back to Dr. Stacy. What happens if someone knows they have PCOS or is diagnosed with it, but doesn't treat it? What are the ramifications of basically failing to do anything as far as medical intervention or dietary or nutritional intervention?
So the problem with not treating it, especially if you're not having periods, is that unopposed estrogen really can cause a lot of issues. And I would be most concerned about endometrial cancer in a patient with PCOS and unopposed estrogen that doesn't treat it. Then you also have to look at the metabolic component, because if that's not treated, it can lead to type 2 diabetes, it can lead to high cholesterol, it can lead to stroke, to heart disease, to heart attacks. And so really it's not just the physical, like, oh, I can't lose weight and oh, I have facial hair growth. No, it's really the medical issues of endometrial cancer, diabetes, heart attack, stroke, high cholesterol. So it really does need to be treated because it can get significantly worse. And if you treat it sooner than later, it's much more easy to control than if you just come in and haven't had it addressed for numerous years.
Excellent. So this is not something that we want to just say, well, I'll talk to my doctor when I get a chance, or I'll deal with it later, or whatever. This is, and it's not just an inconvenience kind of condition. This is something that is fundamental to our overall general health.
Yes, absolutely.
Okay. Felice, one of our viewers has a question, and I'm actually interested in this too. Can you tell us some more about the health at every size philosophy and what that refers to and what it means? And, I think our viewers are interested in hearing a little bit more about that.
Sure. So I like to preface this by saying everybody, not everybody, a lot of people have different interpretations of what health at every size means. And definitely it's been applied to many different social movements and feminist movements and all of that. So I kind of based the way that I describe it or practice it from the original Health at Every Size book and philosophy that was written by Dr. Lindo Bacon. And sometimes I kind of rephrase it as not health at every size, meaning everyone can be healthy at every size, but finding what size you are healthy at. So the way I kind of describe that is, let's get your mental health under control, your lifestyle behaviors, all of that, give you a really nice, sustainable, maintainable, healthy lifestyle. and see what happens with your weight. Does it go up? Does it go down? And once it's kind of plateaued and stabilized, and in addition to that, labs have improved and we see maybe cycle regularity, a resolution of some symptoms there, that tells me that you have found your healthy weight. And it doesn't have to be in the healthy BMI scale. In fact, it's better to go in without expectations with where your weight may fall, and just really trust that your body knows what it's doing, trust Mother Nature's blueprint, and really focus on what makes me feel good, what seems to be giving me good health, and not really let the rest or those, very generalized population level parameters like BMI affect your perception or your relationship with your body and with your weight.
Wonderful. I think that's a really healthy approach to looking at it, because every one of us is different and we need to acknowledge that one size does not fit all. And it's really important. Okay, so I have a question for both of you, because this is something that we run into a lot and our viewers have a lot of questions about that. And so some of our viewers are certainly happy patients of Paloma practitioners, but there's a lot of folks that love to come to these speaker series events who are with regular doctors in their own areas, and they're not Paloma patients, but they are sometimes struggling when they are going in with some of these kinds of symptoms that can point to either Hashimoto's or hypothyroidism or PCOS and insulin resistance types of hormonal imbalances. So, a typical story that we hear all the time is, I went to my GP or my primary and I said, I'm tired, I'm gaining weight, I'm noticing I'm getting some hair on my chin, and, my hair's falling out of my head, and I'm tired and I'm sluggish and I'm feeling a little down and in the dumps, and I'm blue. And some of them are being told, well, you're stressed, depressed, PMSing, get off the couch, eat less, let me give you some Prozac. And they're not doing a workup for their thyroid. They're not doing a workup on blood sugar. They're not looking at other hormones to check and see what's really going on. There's a tendency when women go in with emotional symptoms to give them an emotional diagnosis or a mental health diagnosis. So, Dr. Stacy, I'm wondering, as a physician, what do you recommend to those patients who aren't fortunate enough to be your patient or to be with one of our Paloma practitioners, who is getting a little bit of the take some Prozac, you're stressed and depressed, run around from their current medical care practitioner?
So I would say get a new medical care practitioner. For example, I just got through seeing a patient before this talk, and it was the same thing. She actually had bariatric surgery, and so she lost a significant amount of weight, but she was still having facial hair growth. She was still having difficulty losing weight. She was having irregular cycles, and she was also very anemic because when she does have periods, they're very, very heavy. So her primary doctor put her on Lexapro and said, oh, you just need to lose some more weight. So she was very frustrated, obviously, with this. And so she found Allara and came to me. And so she's getting, taken care of. But that's what I would say is, if you're not happy with what's happening, then find another physician. There's a lot of physicians out there, and you just have to, obviously you don't doctor shop, but you go to one that you can. I think especially with women's health, it's very, very important to connect with your physician, because it's really, OBGYNs, they see a lot of very sensitive things, and we talk about a lot of very sensitive topics. So you have to really connect with your OBGYN or even your primary care doctor. So I would say just find one that is an advocate for you and that doesn't just brush you off, but actually will listen to you. So yeah, that's my advice, find a different physician.
Thank you. Felice, do you have any thoughts? Because I'm sure you have heard some of the stories from some of the folks that you have worked with as well about being brushed off or told it's in their head, or, get off the couch and eat less. And, my personal favorite was one of my coaching clients had an endocrinologist who told her she had fork in mouth disease and that she needed to eat less. And that was the whole problem. Turned out she had both hypothyroidism and insulin resistance. I don't think she had PCOS, but she was extremely insulin resistant and hypothyroid. And once she got all those things resolved, a healthy diet and exercise started to work again. So what are your thoughts and advice for women patients who maybe are getting a little bit of the runaround, Felice?
So first, kind of going off of what Dr. Henigsman said, absolutely advocate for yourself. Find a physician who seems to be listening to you and, really taking your concerns seriously. And then just kind of to add to that, don't stop until you get satisfactory answers, or at least you know that you're on the right path. And then when it comes to any provider that says, just lose weight, or your issues that you're eating too much or this or that, it's just absolutely really ridiculous, because nobody wakes up and chooses, oh, you know what, I'm going to go on an expedition to gain 100 pounds this year. No, nobody does it. And the amount of times that, hundreds may be an exaggeration, but the amount of times that I've seen patients gain 40, 50 pounds, and my experience, going through that same thing, it's so clear that for a provider to say that, they clearly do not understand the pathophysiology or even really the underlying causes of any medical condition relating to hormones like PCOS, Hashimoto's, etc. So with that, I would say mental health first, just like beforehand. So let's say that, really truly the issue is overeating. Why is that overeating being caused? It's not just listening to your appetite. Your appetite tells you really what you need, but is it that you're struggling with maybe some disordered eating patterns like binge eating, or some cycles of restriction and purging? Or could it be that, you aren't eating regularly enough throughout the day, you get really hungry, and then you have a giant meal and realize you overate? So finding whatever those root causes are for your behaviors is very important. Taking care of mental health first, trying to get active as much as you can. Both of these conditions make you fatigued, but getting regular sleep, then getting exercise whenever you can, using common sense nutrition, and just kind of leaving it at that. The answer is not supposed to be complicated. It's supposed to be something that's maintainable and sustainable for the rest of your life.
Wonderful. Thank you. And I'd like to just add that, I feel like life is too short to spend a lot of time trying to educate our providers and practitioners. And when you have a condition like PCOS or Hashimoto's and hypothyroidism, certainly there's a lot of people who have great doctors that can handle it. But my recommendation is, if you're struggling and if your doctor's not great and on top of it, go to the people who make this their business. Go to the people who are doing this day in and day out. So that's where something like a practice like Allara or Paloma are so incredibly valuable, because you do not have to bring your practitioners up the learning curve on these issues. You can't expect every doctor to know everything about every condition. And, your GP or your family doctor may not be completely up on everything related to Hashimoto's or hypothyroidism or PCOS. They'll have a broad brush idea of what to deal with. But when we're doing these kinds of conditions and we want to really get to the root of it and deal with it and feel well, sometimes just going to the experts that are doing this day in, day out can be a really excellent way to approach it. One last question that we have before we wrap up is just how can women tell the difference? Because I think this is probably one of the issues is and we have the same problem with menopause and thyroid, because the symptoms of thyroid, the symptoms of menopause, and in this case, the symptoms of PCOS, there's a lot of crossover. So rather than, wandering the desert for 40 days trying to figure out what our diagnosis is there any sort of direct path to getting to an answer? So Dr. Stacy, let's throw that one to you.
So, I think it's kind of what we talked about. You need to go into your physician with all your symptoms. You can even write them down if you'd like, because sometimes that's when some people have white coats, and they're very scared of doctors, so they forget everything. So I would just recommend write down all your symptoms and just say, well, I looked this up, or, I went to a meeting and this is what they were saying. So do you think this is something that I could have, or can we explore this a little bit more, maybe get checked out for this and then just see what they say? But yeah, I would definitely approach your physician and with all of your symptoms and then go from there.
Great, thank you. Okay, well, I think we're coming up on the 1 hour point. So I want to, before we turn it over to Katie to finish up things, I want to just thank Felice Ramallo and Dr. Stacy Henigsman for being so informative and so passionate about a really important topic. And you will be getting information, I'm guessing, that Katie will be able to tell us, but if you need to touch base with the folks at Allara and wish to consult with either one of these amazing practitioners, we'll have information for you on how to go about doing that. So again, thank you very much to both of you for sharing your wisdom and your empowering information for women, because I know it's going to make a difference for some women out there who have watched the program. And so thank you. I found a lot of this really informative and interesting, and I am going to turn it back over to my co-host, Katie.
Thanks, Mary, and thank you to both of you for contributing your knowledge and experience. One of those questions was mine, so I also find all of this information really helpful and interesting. And something that stands out to me is your not only empowering people with information, but the empathy that both of you show, and the way that Allara is approaching health as a whole body thing. Because like we know at Paloma, living with a chronic illness is not just physical, like there's a huge mental component as well. And so I appreciate you sharing that with us tonight. Thank you to all of you who have joined us and spent an hour with us today. We will make sure that you get the replay in your inbox within 24 to 48 hours. And there will also be information there about how to contact Allara if you need more information about PCOS. So thank you all very much, and we will see you at our next speaker series. Good night, everyone.
Thank you.